think this last session is going to be half an hour max. At 4 o'clock, I think we have to stop, and at 4:30 there's transport to the airport, I think. So, Ignacio, I'm going to invite you immediately to start your talk about key insights and voting outcomes from the 2026 program.
So, in the next few minutes, I'm going to try to summarize what we have done in these last two days. So, first of all, I would like to thank you and to express my gratitude to all the board members. I know the amazing job you have done in this last few months. And also, of course, I want to thank all the attendees, all the speakers, moderators for a great job. So the first session yesterday was the welcome by Philippe and Nina. And also we asked what are the type of attendees that we have this year. As Philippe explained yesterday, we are more than 100 people here in this meeting, and most of us are cardiologists, and most of us are left atrial appendage occlusion implanters, but also we have several left atrial appendage closure imaging specialists, and also industry. I think that the numbers were around 40 people from the industry. So we set up the framework for this meeting, and we discussed a little bit what should be the consensus theme for this year. And as Nina explained yesterday, we have moved from procedural excellence, so we have discussed about imaging, anatomy, all these kind of things, now move to patient selection. That was our pick. But anyway, we asked the attendees, what do you think about this? So people say that all of us, not all, but I mean, almost all of us, 96%, agree that this year should be patient profile in left atrial appendage occlusion. And also we discussed what we consider consensus or agree, and it was or 50% or 66%. So most of you think that 66% should be okay. After that, we discussed clinical trials and new data on left atrial appendage occlusion, and both registries were presented, the US registry by Dr. Freeman and also the ELAACC registry. So we discussed which are the differences between both registries. Of course, there are a lot, but in the discussion, we decided that these are complementary registry, and also we discussed potential projects, mainly based on the difference in clinical practice between US and Europe. As you know, there are differences in which are doing the cases in US or Europe, interventional cardiology or EP. Combined procedures are quite popular right now in US, and also there are big differences in post-treatment. Another point that we discussed is that in the ELAACC registry, we have data to predict or try to predict ERT, and in the US registry, they have long-term follow-up based on the Medicare data. After that, Xavi present what we have done or what we can do with the ELAACC registry. So he proposed to have some kind of quality of life paper, and also he discussed, and probably we are going to discuss later with Adel, if we need a dedicated score for this type of variables. And also Dr. Freeman proposed, and also we have discussed this today, a general paper that probably makes sense just to describe what we are doing, which is the ELAACC registry without the patient. I mean, just to show what we are doing right now. We have also a voting in this session, and we propose several topics for the ELAACC registry paper for this year, and most of you think that antithrombotic treatment after left atrial appendage closure should be the topic that we should address, so we should do this. After that, Philippe presented the LAAC initiative, and also he discussed what is going to be the LAAC 2 initiative, because mainly we need still to address some of these variables, so we need to discuss, and we have been discussing this for the last 2 days, patient profile. Also, probably we need a definition of dedicated high bleeding risk population. We still need some information about management of concomitant procedures, sex-specific outcomes, and of course, and now this is a fancy topic, integrated prompts in our results, and probably additional methodological and clinical gaps need to be defined, so this is the LAAC 2 initiative. After that, it was a great session because we discussed what we have, the new data. This is quite interesting, and initially Tom presented the ALONE AFib trial, and we have again here several poll voting. So based on what Tom presented and the data of the ALONE AFib and the OCEAN trial, 82% of the people here believe that we can skip oral anticoagulation post-ablation in patients with low risk, so CHADVAS 1 or 2. And also we consider that we should not skip oral anticoagulation in patients with previous stroke. The last question we did was if we should monitor for recurrent AFib and which method, and most of us think that Apple Watch or similar should be the way to go, so it was almost 60%. After that, Carster present closure AFib. I think it was a great presentation, really nice presentation. And also he made 2 comments that I think is really worth to take into account. So probably dual antiplatelet treatment is not the way to go. We have discussed this during the whole meeting. And also he presented that if procedural bleedings are excluded from the analysis, the results are not so bad for left atrial appendage occlusion. So we have 2 questions here. One was if now we should change after the results of closure AFib and forget about left atrial appendage closure as a stroke for prevention strategy. Of course, we say no, so 95% of the people say that we still, even we have the closure AFib results, left atrial appendage closure should be a strategy for stroke prevention. And of course, and it was a big point of discussion, we know that this is a selected population, so we should take this into account. After that, champion AF was presented by Jens Nielsen, and we have a lot of results. He presented that probably the difference in stroke, that was one of our major concerns, was only 0.33 per year. So we consider, and this was not, it was only 60%, that we, based on this result, we should make self-decision-making approach for stroke prevention in this patient. There were 32%, so it was not a big consensus that probably we need to wait for the 5-year follow-up results just to think what we are going to do. The session 4 was about patient profiles and emerging indications. So we discussed left atrial appendage closure in hemodialysis patients. And we have another questions here. What was the preferred approach for stroke prevention in hemodialysis patients with atrial fibrillation? 50% of us said individualized decision. Also, we discussed that there are several trials, and we really believe that most of these patients should be included in trials, so we will have data, strong data in the near future. And as you can see here, again, based on the results, almost 50% in both questions, asking what we will do in a patient with end-stage renal disease and no prior bleeding, or with prior bleeding. Anyway, we said that individualized decision because it was 50% and 50%. Also, we discussed about breakthrough stroke under adequate oral anticoagulation. We discussed these three trials at LAO by Sabi, ELAACC by Lawrence, and also LAOS 4. And these are the two questions that we did yesterday. So first question was, should a stroke despite adequate anticoagulation be considered an indication for left atrial appendage closure? 53% say yes. But on the other hand, when we ask what is your preferred approach for secondary prevention of a stroke despite oral anticoagulation, 97% of the people say additional left atrial appendage closure with or without oral anticoagulation. And most of us agree that oral anticoagulation, even if you perform left atrial appendage closure, should be continued. We talk also about patient preference and not compliance. There was a comment about, I think it was Domenico, saying that in patients that don't want to take oral anticoagulation, one possibility is offer also ablation. And this is the question that we did here. If the patient refuses to take oral anticoagulation, what will we recommend or what we are going to do? And most of us say 2% say left atrial appendage occlusion. The last session we had yesterday was about the development of a novel scoring system, and we discussed a lot of ELAACC registry and also ELAACC classification. So I think Jens did a nice summary of the session. So we have three topics here. One is anatomical score, so the ELAACC score can predict complexity, so probably we need to analyze time, recapture, things like that, not just PBL or DRT, because for PBL and DRT probably we need something more sophisticated. We can say, I don't know if with the tool that Sergio has presented we can do that. And also we discussed a lot, and Adel is going to present this. We consider we need to develop a clinical score. So we performed several questions about which variables should we integrate in the clinical score? I'm going to make a quick summary. So most of us agree that age should be included, and the cutoff is 80 years. Also, we discussed about frailty, and we consider that the ETF score more than 3 or 3 should be included. Also, chronic kidney disease with a GFR less than 30 should be included. LV ejection fraction, and the cutoff we decided was 35%. Of course, we say that we should include prior bleeding, mainly major bleeding, as you can see there, and also body mass index. Here the question goes just for less than 18.5, but also we discussed that probably we should also include patients with very, very high body mass index. We say that diabetes should not be included. And also, and this is for me at least quite surprising, after all the discussion that we have about futility, we consider that the cutoff should be more than 20% mortality at 1 year. Now it's going to be faster. This morning we discussed LAAC closure and EP-oriented considerations, so we have several discussions, and also Xavi present this concomitant versus sequential, and Claudio Tondo present the possibilities of isolation of left atrial appendage occlusion, as he has also discussed. After that, we have the session about left atrial appendage closure devices. So we present the AMOLED 360, the Flex Pro, the conformal, and the Zenith. About the AMOLED 360, we discuss about the change in the hooks and safety. Mainly for Flex Pro, we discuss about DRT and the new cover that it has. It was a very nice presentation by Ole about the Zenith device, and one nice feature that this device has is that you can inject through the device before releasing, so you can check if there's any leak. And also we discuss about the ACU form and the early complete sealing as a nice tool. We also discuss new tools and techniques. So just quick summary, we talk about ICE 3D, we talk about the stable seat, we talk about artificial intelligence, and also we discuss about remote proctoring. There was not a really poll, but we raised hand, and most of us support the use of remote proctoring after a few cases or second opinion or complex cases. We have a nice session about challenging cases, and we discuss the possibility in some cases double device, steerable sheath, and how to close leaks, in which cases we believe that we should close these leaks. And the last session, that was just before this session, we have reviewed all this proposal for a study, and as you know, finally the proposal of Sergio seems to be the most attractive for much of us. So thank you so much for being here. It has been a great, great meeting. Thank you.
Thank you, Ignacio. You did a terrific work, like summarizing all the brainstorming and the beauty of this meeting, which is definitely not like other LAA meeting, I mean, with all this discussion that we have. So we go straight forward to you, Adel. Based on this voting and consensus that we get, you have to draft the steps and the next consensus paper on patient profiles.
Thank you, Philippe. So this is episode 2, because yesterday I didn't have a lot of time to talk, but it's the same today. But yeah, I think one of the things that we want every time for each meetings to end up with a consensus about what has been discussed during the meeting. So we have discussed a lot about, because of the new trials, Champion AF, Closure AF, all the data that we have, recent data that we have to deal with. We have discussed a lot about in which patient will benefit or will not benefit from this procedure. And I've talked yesterday about these early mortality issues, which can be high in some registries, and we said that we have to try to find out in which patients the procedure will be futile. So a futility is a procedure that carries a risk, but insufficient time to benefit from the selected procedure. Then we talked about Closure F. There's a big discussion about the patients that were included in this randomized trial, and the answer was to better select the patients. And at the time being, we don't have a clinical score to assess in which patient mortality will be high and in which patient we estimate that the procedure is futile. So that's we discussed yesterday. It's just a project at the time being, and of course that will be also be included in the consensus as a future project. So to identify clinical parameters associated with high risk of mortality after LA closure. I've shown that yesterday, but I would like to show again that in some registries, you have patients at low risk, like in Champion-AF, like a randomized trial showing a low mortality, but in some randomized trial or some registries, mortality, 1 year mortality is extremely high. And just going back, I showed again this registry because we have already like independent predictors. We see that they have included like a little bit more than 800 patients in this Spanish and Canadian registry, and there is a 15.5% death within 1 year. So they had enough events to calculate 5 independent predictors. Very importantly, the procedural success, something that we need to agree on, is that you can have a good procedure, but the patient will die from comorbidities. So the procedural success will not determine the 1 year outcome, in my opinion, but we can still discuss that. So here there were like 5 predictors: age, which here was dichotomized, BMI, diabetes, EGFR, and heart failure, previous heart failure. And there's already a risk score already available in the literature that we could, this is discussion that I just had with Xavi now, that should we validate this one, or should we go and try to find out a new risk score from the ELAACC registry? So that's a question that is open. And you see here, for example, if you add 3 risk factors, or you go to 4 or 5 risk factors, you end up with mortality at 1 year above 30% or even close to 50%. So really a patient that you will treat that will die with a high likelihood of dying during the first year. And the same group, as I said, showed yesterday, also assessed frailty score, a very easy one, the essential frailty tool, which is relatively easy to perform even at the bedside of the patient. And they showed also that on top of the clinical variables, this score was also associated, when it was high, more than 3, at least 3, with a very high mortality as compared to patients who were not frail or just pre-frail. And this is also important. So as Ignacio has shown, there was 2 large consensus. So the first of all is that the consensus should define which is the best patient profiles for LA closure. And the second thing is that the clinical score on top of the anatomical one is needed. So now, the consensus statement, it will focus on patient profiles. So this is a mix of evidence and expert agreement that we have voted all together. So which will try to define the document, the typical good candidate for LA closure, which profiles we should avoid because the patient has too high risk or a high risk of mortality. We will, of course, develop the emerging indications that were developed during the meeting, and the consensus rule that we needed at least 2/3 to have a strong agreement within the group. The next step is to end up with this kind of clinical score and should be data-driven. Maybe it could be registered as part of the ELAACC registry or any kind of multi-center registry that you are able to perform. We need to derive the 1 year mortality from the ELAACC registry. There was a big discussion yesterday about should we include already dichotomous variable or just continuous variables. I would show you that in the tri-score they did it like a mixed, a hybrid approach. Then we need, as a classical statistical approach, internal validation to do the score, external cohort, and you need to define the threshold, futility threshold, sorry, for 1 year all-cause mortality. Just showing back because there was a big discussion yesterday, and I just want to show that it's difficult to see, but on the variables that were put in the tree score, you see that they put continuous variables, but also dichotomous variables in the same way to analyze the independent predictors. I think the LAAC field just faces the same challenge, and we need a clinical score because we have a very heterogeneous population, high variability in outcomes, so we need that kind of clinical score. This is just an example. This is the tree score. So just they ended up at least not with continuous variables, but with dichotomous variables. And all these dichotomous variables were included in the score. You see there was a cutoff for age, there was a cutoff for ENIA functional class, there was a cutoff for example, daily dose of furosemide. So all these dichotomous variables were included in the score, and this brought actually a very high prediction for mortality in hospital and 1-year mortality. So there is pros and cons, but I think we should include both. I think we should call it R variables as continuous and derive the model with continuous variables and dichotomous variables to end up with a simple bedside score that we can back by a rigorous validation. So that was the result of the vote, which dichotomous variable we want to include in the clinical score. And this is just a glimpse into what could look the clinical score in the future. We end up with very simple clinical parameters that we can really do easily, we can collect easily at the bedside, and we could end up with like kind of risk bands, you know, going from low, intermediate, high, futile, every time with a predicted mortality. And you see, for example, if it's a high, then we should envisage the procedure with caution, with shared decision making, and we should set up a threshold when we see that the expected 1-year mortality is too high to consider the procedure. And the vote yesterday was that this futility threshold, this 1-year mortality that we should not accept, it was 20%. But you see that it was the consensus was for this threshold, but still some people say that 30%. So can still decide what will be the threshold for futility when you should really not go into this procedure. So how can we validate this score? I think we can use either what was published before and validate it in the ELAACC registry, like Xavi said, we just had this discussion like 5 minutes ago, or use the ELAACC multicenter registry either for recalculating independent predictors or for validation. The only thing is that the study I showed from Spain, they had a high rate of mortality, so they had enough events to calculate independent predictors. So we should end up with a population with enough events to have those predictors. If it's a very low mortality, then we need a lot of patients. So let's see what we get from the registry. And also it's very important that we decided to include a frailty score, and this should be collected prospectively. And so that's another point that we need to decide upon. Ignacio has already shown that the other agreement within the audience, and I would just summarize the next step. So the consensus will be the patient profiles for LAAC. That will be the focus of the next consensus paper. And the future will be to dedicate a clinical score to assess which patient benefit the more from this procedure, try to define a futility threshold and use whatever we have. But I think the ELAACC registry is really the good tool to validate and to assess this clinical score. So thank you.
Thank you, Adel. That's brilliant. I think it's the best way to reconcile all the data we had this year with all these trials, champion, closure, and all, and we will proceed. Ole, you have the task to invent the future with the community, so.
No, maybe first still on Adel, I mean, I think it was brilliant what you showed. It's really something what is needed, but I want to ask here in the audience, like who gets referrals, yes? Who of the referrals for LAA closure, at least 10 to 20% of these referrals refuses therapy for these patients? Who does that? Yeah, if you get a referral for an LAA closure, you make some selection, and let's say 20% of the referrals you get referred to you, that you say, no, this patient he would be too high on the score here for futility. I don't offer, I say no for this patient, I bounce him back. Like, few.
But 20, I mean.
At least 20%. But I think, look, if we come with this, you have to be open to this, yes? I mean, we even in Copenhagen, we say no to 30% of the referrals we receive, or even more, close to 40%.
Because you have a lot.
No. Yeah, but that's the bad spirit. So if you just treat the patient because you want to do the procedure, that's not the way to go, yes? So you have to be open. For example, all these patients with an EGFR less than 30 millimeters per minute, don't start with it. These patients are nearly dead. They're half dead. Yes. So, treating these patients, that doesn't serve anything. I mean, you see also in the closure EF trial, 25% of their patients have severe renal function. That's like a patient who has one foot in the grave already. You just before he dies, you put in a closure device. That doesn't, I mean, that's not the way to go. But anyway, so I think if we work on that, we have to be also open and realize that in the future we will have to say to a significant amount of our referrals, no, we're not going to close your appendage. So you're going to lose volume by that.
No,
Yes.
no, that's for sure. I completely agree. And the thing that I also wanted to mention, and you know, going back to the ELAACC registry, that apparently we need to add just two variables in the registry. One is the frailty, okay? So I will speak with Anders. And the other one that I don't know if we should also implement, you know, like diabetes is in the CHATS basket, but insulin dependent, it's not. So should we put it, or it's, you know, just...
Okay, that can be worked on later offline also, I guess, but indeed we have to discuss
No, frailty
this,
for sure, so, well, we will...
Yeah. But I want to hear also, yeah.
Ole, I very much like what you're saying. I am completely supportive of the idea, but I also want to say that we should be careful not to push it too far. I disagree with the idea, for example, that a GFR 30 patient is half dead.
That's now said indeed in extreme, but
yes,
I mean, we have to be very critical.
But the point is, the patients we are seeing for referrals are not healthy patients to begin with, else they would not be referred. And I mean, we are treating cancer patients with monoclonal antibodies for a few million euros for an extension of survival of 2 months.
But
if
yeah,
we can
with
offer
closure
a
EF, it seems
reasonable
we
quality
even
of life
harm
for
the
1
patients.
year, for me is an acceptable indication. 1 year quality of life is okay.
But with these cancer treatments, typically you try to make the patient still better. In closure EF, it seems there's even a signal we damage. I mean, we harm the patient more than we.
There needs to be a threshold for sure. And if you will not survive a year, I agree. But let's.
No, but indeed,
But
I mean,
that
it was a
will
little
be,
bit.
that will be the beauty of having a score, because if you take the variable individually, maybe you have less than 30, but you are in a good shape and so on.
It's
And
always
that's you add on top of that dementia and very old age and blah blah blah, and then
Frailty.
then the risk is super.
Okay, it's going to be interesting too. Also, if you work on a consensus document, just, I don't know, it's just to throw in the group as well. I mean, I've been involved now lately in the last year in 2 consensus documents to get it really in a decent journal. What they ask and demand is, but it's mandatory that you use a Delphi method. I don't know if you, so just coming up with a consensus document these days that doesn't, the journals don't pick this anymore. So the Delphi method, it's something like you have to be, among experts, have to have 80% agreement. If not, you have to rephrase your statement until you have 80% agreement. So so there are some strict rules for that now these days for journals to accept consensus papers in that way. And then maybe for the future, for next year, well, I think another idea I want to maybe throw in the group, if the ELAACC registry would come to run, I think this could be an ideal tool to do some cluster randomization. I don't know if somebody has heard about this, but we're going to start using this in the Nordics for the TAVI. So there's some connections between different centers in the Nordics where we use the same REDCap database. And what you can do is cluster randomization. So that means you, for example, easy topics. Let's say you want to investigate for TAVI, for example, is a bifemoral approach for your pigtail or for your radial. Yes, you could cluster randomize, or which antibiotics for infective endocarditis prophylaxis, or is aspirin as good as clopidogrel or double antiplatelet? And the great thing is that you don't need consent of the patient. Yes, so you can just do this, and then you say the cluster randomization will decide, for example, if you treat the patient in an even week or in this month, then you will have to do all this kind of arm of the randomization. In the other week or the other month, everybody who participates will have to fall into the other arm. So in that way, you can do in a big cohort without consenting patients. And so you can do this. So I don't know, is that something which some people are thinking of using? And I think this would be excellent, because in that way we could really produce prospective, randomized data and results, and we could really contribute to the field, not just on some 100 retrospective study again, which is very selected bias. So I don't know. Because it's cluster randomization. You have to, of course, it should be standard therapies that people use anyway. Yes, it should not be something completely new, experimental. But if, for example, sometimes you use aspirin or clopidogrel, that's kind of equally perceived in the clinic. You do that already. So ethical committees, in the Nordics at least, they approve this, that it doesn't have to go through ethical committee. You don't need consent from, sorry? It's a European law. Okay, so it's a European law. So I think this is where we could really make a difference, you know, in the ELAACC registry. If people participate there and you say, we cluster randomize, you click in the registry, okay, I participate in this cluster randomization for let's say, clopidogrel versus low-dose DOAC. You can click on these things, and then, of course, you can put some criteria that your patient should fulfill on certain criteria. Then you could do really randomized prospective trials in a very easy way. Yeah, so I think this is something we should really discuss and consider doing. And then for the last 5 minutes, I want to hear, I'm not going to talk, I want to hear what should be the focus for next year. So this year was more the patient selection. The year before was more on imaging. So what should be the focus for next year? What is the appetite and the interest in the group? Can somebody voice out what he or she would like to see being discussed most focus on? Back to the procedural, some procedural aspects, or what is the appetite? Nobody wants to? Tom, what would you like to see? What focus?
Intuitively, when you said it, I was thinking back to something procedural or something more on the technological aspect, because we covered patient profiling, we covered imaging. I think it's worth going back to device innovation. There's a lot of stuff coming out. I think it's worth focusing on...
Or steerable sheet, not steerable sheet. I mean, that was my thought too. I mean, going back to basics to what there's many implanters. There's also imagers here, of course, and we had a big topic on imaging last year. So maybe going back to the real technical aspect could be attractive for me, but I don't know. Yes, Lisbeth?
Now that you are, I'm just thinking out loud. What I learn most, especially from the last hour, is that we learn so much from non-physicians, from engineers. They have a completely different mindset of thinking, and if you put a doctor together with an engineer, you get these nice images of Sergio and of Jordi. I think we can still learn a lot about patient selection and anatomy, device selection based on new technologies, new software. That is not something we are familiar with, but we need to collaborate, I think, with non-physicians, with very smart people, engineers.
New technologies, kind of.
No, gaining new insights based on AI models that calculate. Sergio's model can show us this patient should be treated better with this, or this big left atrium should not be treated with an appendage closure. You can leave him without an appendage closure, for example. I think we should think outside of the box than what we are used to, and have more AI, it's a stupid word, but more other technologies coming into our field. Because otherwise we're always talking about the same things, while I think there's much more potential out there.
Yeah, I'm thinking with
Ole.
the last comment.
Yes?
Probably, maybe we need to integrate also the atrium, you know, because we focus a lot in the
Integrate the
appendage,
what?
in the patient selection, and maybe with treatment we are going to give the patient afterwards, based not only in the appendage, also in the atrium. Because if you have an appendage with an atrium that is not moving, with low flow, it's not the same as small one that it's contracting. So I don't know, just integrating in what Lisbeth was saying, that probably with this AI tool, we can also put that.
And also with all the ELAACC data, I'm sure that we will gain new insights based on the clinical data if we let the machines decide which criteria are
I
good
hear
or
an
not
appetite to go on to the AI. What can it really contribute? What not? What is AI? Because I mean, I think there are a lot of discussion. Some people interpret some things as AI, which is not AI. It's just computational, something further pre-planning. But so that could be good to make us wiser about that topic. Yes, I don't know. Yes.
Yeah, I think we have now the two large studies, Closure AF, and we have Champion AF, and it's just the initial primary publications. There will come a lot of sub-studies from both Champion and I suppose also from Closure AF, so we can get a much better understanding on the strokes that are in Champion AF, for example. So I think there will be a lot of clinical data still to need our interpretation.
Yeah, okay.
And I hope also for next year we will have the simplified trial. That will be probably some of the most valuable data for post-procedural medication. And so I think we need to have still the clinical data in focus for next year.
Okay, so more, okay, good. That's your proposal, to go more in depth on the data, that's the clinical data that's going to come?
Yes.
Yeah. Okay, Sergio?
I have a proposal. I think we could send a call for ideas, 2 weeks, for send one row with the proposal, so everyone will have time to reflect and to send a proposal. After that, we have a list of a proposal and we decide.
Okay, that we ask the participants to say what they want to hear?
An email to everyone, to all the participants.
They can email.
No, that I mean that maybe Alexandra or Benjamin.
Oh yeah, yes, yeah. And then a poll. Okay, so you want us more to get some topics, the topics that were mentioned here. I'll try to memorize them.
Just few words with the topic.
Yeah.
AI
okay.
or what else.
Okay, that's a good thing. Like a poll, we can do that with the topics that have been brought up here. All right, that's good. I think, okay, Philippe is gone. So I thought he was still on the point. No. Okay, no, but good. I mean, we will do that. Then we can hear and adapt, hopefully, for next year, the program a bit in that, in the direction you ask us to go. So with that, I think I want to, yes, complete on behalf of everybody, yes, because I'm not talking for myself, but I'm for the whole organization, Alexandra, the whole organization behind, and also the faculty and all the participants. Thanks for being here. Also for the company supporting this meeting, of course. Without them, we couldn't do this. So thanks for everybody and safe journeys back.